Ultrasound study of a 35 years male, and this is my scanning plan. I am in the intercostal space. This is the subcostal region. This is the intercostal space 7. And I place the probe here, then I angle it towards the patient's left shoulder and then angle it a bit as per my requirement. You will also have to do the same. Let's see, and let's see what is the outcome of scanning. What are we seeing here is that this is the picture in front of you is that of the gallbladder, and you are seeing tiny echogenic particles giving posterior shadow from this view. Now this is the fundus of the uterus, fundus of the gallbladder. This is the, I'm sorry, initial 2-3 patients for those or that of uterus, so it slipped from my mouth. This is the gallbladder, and this is the fundus, and these tiny echogenic particles are consistent with the gallbladder calculi. This measures 3.6 mm, and the wall measures 5.5 and rather 4.8, and this is a thick wall, keeping in view that he is with overnight fast. This is the liver, and all these tiny echogenic particles are giving posterior shadow. This is the shadow. These shadows. No liver parenchymal disease is seen. Now this is this ultrasound in supine posture. Why this is gallbladder and not some other structure? I am going to ask the patient to take a deep breath. I am in the same intercostal space and angling the probe towards the patient's left shoulder. I am going to, now one thing here, see, this is the portal vein and this is the common bile duct, not dilated. But the size of the stone is such, see, one of these is in the neck region, this one, and the size is approximately 3.4 millimeter, and the problem with these stones is that they can slip into the common bile duct and lead to obstructive jaundice. And however, in this case, so far, he is lucky not to suffer from that. Now this tiny calculus is giving posterior shadow, as you can see, and now again patient in supine posture. Here you can see another view of the portal vein and common bile duct, not dilated at all. See, this is the portal vein, this is the common bile duct, and this tiny cystic area is the hepatic artery. So in supine posture. Now I'm going at least one intercostal space down and going to ask the patient to take a deep breath and hold it. Lamba sa leke saans rok lein. I don't see any significant change. Okay. Now, patient in left lateral decubitus posture. Why? In this case, though I have seen the pathology, it's because the fundus is being cut off. I'm not getting the fundus completely in supine posture, and this is a row of tiny calculi. They are mobile. Why mobile? You see, now in this posture, when I'm going to scan the patient, you will see a change in the position of the calculi. Now you see them with the posterior wall of the gallbladder. And my scanning plan is patient in left lateral decubitus posture, place the probe here, and then here. This is my subcostal region, and I am with the intercostal space, but now below the costal margin here. And again, I am going to ask the patient to take a deep breath and hold it. Lamba sa leke sa roko. So first thing that I noticed that there is change but in the position of the calculi, and this is the gallbladder wall. Now you see that even the gallbladder wall is not appearing that thick as it was in supine posture, something around 3.8 with a normal. So the wall is not thick, and this is the liver around the right hemidiaphragm, and these tiny areas giving posterior shadow, sharp posterior shadow, are the calculi layered out with the posterior wall. Now note another interesting thing. Always see the fundus of the gallbladder, because you may miss calculi in this area. As you can see that there are calculi in the fundal region. This is 1, 2 and 3 giving posterior shadow. Now we were missing this. Suppose there had been no calculi, these calculi were absent, and only these calculi were present in any other given patient, then you would have missed this and given a normal report. Always see the fundus of the gallbladder so as to see if it is clear. Most of the time they are seen in the gallbladder fundal region. Now you can see that there are multiple calculi in the fundal region, not only one, there are multiple calculi seen in the fundal region. And here we can depict both. Now see the scanning plan. The scanning plan is with patient in left lateral decubitus posture. This is the subcostal line. I have placed the probe. Now I am not performing the ultrasound in line with the subcostal region. Initially I was doing the scan in this, placing the probe vertically below the costal margin, mid-costal margin, and then angling the probe towards the patient's left shoulder and then angling this way. Now to see the fundus, I have to rotate the probe about 30 to 40 degrees and then angle it as per the wherever I get the accurate picture for me to depict the pathology. Now if not, then ask the patient to take a deep breath and hold it. You will get the total picture of the gallbladder. So these are two methods, and one is that of in standing posture, in case if you want to be very accurate, if you are not getting the gallbladder properly, because remember that the position of the gallbladder in every patient is different. It's not placed in one particular location. So at times it gives you a tough time to get to the gallbladder and see. Now you see that by placing the probe in this position and angling it, I am angling now, and I can see there are multiple calculi in the gallbladder. These are all calculi getting sharp posterior shadow. This black area is because of these gathered together tiny calculi. And then I can maneuver the probe and I can see the lower portion. Here you see these are calculi in the independent region, and they are layered out with the posterior wall. So this is how we should scan the gallbladder case of any case, given case of a gallbladder, and so as you don't miss any finding. Okay, now give it 90 degree sweep to the probe to get the transverse section of the gallbladder. This is the 90 degree sweep. This is the transverse of the gallbladder, and these are few gathered together calculi at the dependent region. Another important thing to remember, now the patient is in supine posture. Remember that the bowels, at times you see the bowels may at times indent into the posterior wall of the gallbladder. This is the bowel. Why it is bowel? You will see movement in this, and you will see typical artifacts from ring out, ring down artifacts, as well as dirty shadow from the bowel. And these are calculi. They will now, when I am scanning in this posture, they will not change their posture. They will remain there. They will change their posture, position when I change the posture of the patient. And now, if you concentrate on this area, this area, now anyone can label these row of tiny echogenic particles as being GB calculi. Well, this is a very tricky thing. Be careful. See, this is the posterior wall of the gallbladder, and this is something outside the gallbladder, and it changes its shape. See, it will change its shape, and you will see different shadows from it. Not the kind of shadows that we see in. Here you can see the movement here. You can see the movement. However, when we see the calculi, they will remain where they are unless you ask the patient to change his posture. Yeah, see this. You will see again a shadow from this area, because these also appear as calculi. Now, true calculi are these ones, giving sharp posterior shadow. Concentrate on this region, this one. You can see that so be aware of this portion. This is a tricky one for the beginner, and this video is for the beginners. You can differentiate between the true calculi and the false impression of bowel gases or bowel food material blending into the posterior wall of the gallbladder. Thank you very much. This is